Welcome to AETCM, the Emergency Medicine Channel. Today, let us discuss about transfusion-related acute lung injury or TRALI. We know that whenever we transfuse blood, we will be transfusing for various reasons. It can be due to anemia, it can be due to thrombocytopenia, it can be due to trauma, whole blood loss. There we give whole blood. Sometimes we give FFP, fresh frozen plasma, cryoprecipitate. So many products we transfuse when it is required in a patient who is having deficiency of specific factors. So when we are transfusing blood or blood products, there is a high chance of fluid overload. That means when you are transfusing for anemia, like already fluid overload is there, we give another 1 or 2 pints of blood, there will be chance of fluid overload. That time patient can develop pulmonary edema. But TRALI is something similar to fluid overload induced pulmonary edema, but the mechanism is entirely different. Clinical presentation may be similar to fluid overload, but the mechanism is entirely different. It is like ARDS. So this TRALI is a uncommon reaction, results from transfusion of a donor plasma that contains high titer of anti-HLA antibodies that bind to recipient's leukocytes. So here the main problem is when we are giving plasma products, it is not very commonly seen in blood transfusion. That means packed cell transfusion, packed RBC transfusion, it is not very common. Whereas in plasma transfusion, it is the incidence of TRALI is very high. The leukocyte aggregate in the pulmonary vasculatures and release mediators of inflammation and further produces capillary leak and increased capillary permeability. That will produce vascular leak. That leaking solution can go, or leaking substance can go to alveoli, and it will produce something similar to ARDS. So there are it's the mechanism of TRALI or transfusion related acute lung injury is a two-stepped mechanism. It is two independent mechanism. So that we have already seen that one of the main mechanism is donor derived anti-HLA or anti-HNA antibodies direct against the antigens of the neutrophil surface, and they release lot of inflammatory mediators. These inflammatory mediators produces acute lung injury through vascular leak. Another mechanism is the existing clinical condition of the patient, like active infection, history of cytokine administration, surgery, severe burn injury, that causes activation of pulmonary endothelium. That also produces pulmonary endothelial damage and vascular leak and pulmonary edema. Pulmonary edema will be similar to ARDS. That is the main difference between the fluid overload pulmonary edema and TRALI. So there are two mechanisms, first hit and second hit mechanisms. Whatever it may be, whether it is first hit or second hit or third hit, the problem here it is there is vascular injury, endothelial injury in the pulmonary circulation. Through that endothelial injury, the blood or plasma will enter to the alveoli. That will produce like ARDS like features in the patient. Now if you see the histopathology, it will be similar to ARDS. There will be interstitial and intra-alveolar edema with presence of neutrophils in the interstitium and airways. So numerous neutrophils can be seen in pulmonary capillaries and small pulmonary vessels you can see in the section. This is similar to ARDS, acute respiratory distress syndrome. The diagnostic criteria of TRALI: if the symptoms develops during or within first 6 hours of transfusion without any risk factors for developing acute lung injury such as sepsis, pneumonia, aspiration and shock. Delayed TRALI is explained in some literature, that is after 6 hours to 72 hours. But if the trally occurs or breathlessness occurs within less than 6 hours, we have to always think about trally. And after 6 hours, it can be tacho or trally. We will see what is tacho afterwards. So delayed trally can occur even after 6 hours. The symptoms of trally is mainly like ARDS only. Patient can have a high degree fever, hypotension, tachycardia, pulmonary edema like features, bilateral chest infiltrates. Chest X-ray shows diffused, extensive bilateral non-homogeneous shadows. Now you can see here both trally and tacho will be similar in chest X-ray. You can see bilateral diffused interstitial infiltrates. It can be similar to fluid overload. So you can see bilateral fluffy shadows, diffuse shadows throughout the lung fields. CT can confirm it. Now there are two types of trallies, type 1, type 2. Acute onset within 6 hours of transfusion, hypoxemia, PaO2 by FiO2 ratio less than 300 or SpO2 less than 90 on room air. Clear evidence of bilateral pulmonary edema like picture in chest X-ray or CT or ultrasound. We can see B lines in ultrasound. No evidence of left atrial hypertension. If left atrial hypertension is present, it is not the main contributor for hypoxemia. No temporal relationship to the alternative risk factors or ARDS like feature. Trally type 2, same clinical criteria as trally type 1. Presence of an ARDS risk factor or mild ARDS, previously stable pulmonary status in the 12 hours prior to transfusion. So, even when we are talking about trally type 1, type 2, the treatment aspect, it is similar to it's similar for trally 1 and trally 2. Only mechanisms or criteria are slightly different. So trally normally occurs within less than 6 hours of transfusion, especially plasma products. But even if even some patients you can get, even it can come after 6 hours, 6 to 72 hours it can occur. That is delayed trally. Incident of trally is 1 in 5,000 units of packed cells and 1 in 2,000 units of plasma containing components. You can see clearly the difference between packed cells and plasma containing products. It is more in plasma containing compounds, that is 1 in 2,000, whereas in packed cell it is 1 in 5,000, and 1 in 400 units for whole blood derived platelet concentration. So that is high in platelet derived concentration, 1 in 400. So comparing with the RBC and plasma and platelets have got maximum incidence of trally. So when trally occurs, the mortality is very high. That is a problem in trally, whereas in tacho mortality is not very high. If you give Lasix by NIV ventilation, the mortality can be reduced significantly. But here, even with maximum supportive therapy, the mortality rate is very high. And those who survive after a trally, the recovery is also very delayed. It is something like ARDS, blood transfusion dependent. We can even tell that it is a blood transfusion dependent ARDS, but by definition it does not come under ARDS, it is only trally. Now, another important condition which is a close differential diagnosis for trally is TACO, transfusion associated circulatory overload. It is something similar to fluid overload. So whenever there is severe anemia, there will be compensatory mechanism and patient will have more plasma in them. That means patient is fluid overloaded, but RBCs are less in number. That's why they have anemia, but fluid is more. Body try to compensate for that anemia. So fluid overload is there. On top of that, if we are giving blood transfusion without giving adequate Lasix or furosemide, then patient can go to something similar to fluid overloaded situation. So they can have cardiac failure, they can have pulmonary edema, they can have breathing difficulty, hypoxemia, circulatory collapse. All these things can occur. So here you can see cardiac failure, pulmonary edema, and it can be avoided by pre-treatment with diuretics. That's why most of the patients who is having chronic anemia, we always give Lasix before blood transfusion. Whereas in acute anemia like severe GI bleed, severe trauma with bleed, no need to give Lasix because it's an acute problem. Body has not tried to compensate with fluid overloaded situation. Now this is the main difference between TRALI and TRACO here. TRALI BP is normal, TACO normal to high. Body temperature normal to elevated in TRALI, it is not elevated in TACO. Chest X-ray, it is bilateral congestion features can be there. Pleural effusion is mostly seen in TACO, not in TRALI. BNP is low in TRALI, but it is high in TACO. Other things like pulmonary arterial occluding pressure will be low normal in TRALI, it is high in TACO. Ejection fraction is normal in TRALI, it is abnormal in TACO. Response to diuretics, that is the main feature. Whatever we have read in all these lines, it may not be applicable sometimes because many patients who is having requirement of blood transfusion, they also can have cardiac failure. So it will be very difficult to tell whether it is TRALI or TACO. But if the patient is responding very well to Lasix, that is mostly going in favor of TACO. Because TRALI, even if the cardiac failure is there, if the patient develops TRALI, he may not respond to Lasix. That is the main differentiating feature. Edema fluid is mostly transudate in TRALI, it is exudate in TACO. Now, other clinical features of blood transfusion related problem is, one is hemolysis. You can see many patients who is saying after blood transfusion they develop high degree fever, hyperbilirubinemia, flank pains, urine shows hemoglobinuria. Like that you can see some patient develops hemolysis. So acute hemolytic reactions are seen in many patients who are given blood transfusion. So whenever we see that, immediately stop the transfusion. That is the best way of treating the patients. So you can see acute hemolytic reaction. You can see fever with chills. Some patients can have vascular collapse, hypotension, shock, uncontrollable bleeding, that is due to DIC. Vein can be inflamed after some time. Pain in the abdomen, that is very, very classical. Hemoglobinuria, that will give red urine, red color to urine. Hyperbilirubinemia can be there in some patients. Chest pain can be there in many patients. Tachycardia is also common. That's why whenever we transfuse blood, any patient who receiving blood transfusion, after blood transfusion we have to document some important things, like we have to document that patient is absolutely normal, BP is normal, pulse is normal. So if you are seeing tachycardia, then there is a problem. Temperature we have to monitor. And finally, we have to monitor the urine color also. That is very, very important. Any blood transfusion, always document the urine color. Post transfusion urine color we have to document. Suppose the patient's urine color is brown or it is reddish in color, then we have to always suspect hemolysis. So other than that, if the patient develops mild jaundice, that is also clinically important. So before transfusion, always check the patient name, hospital number, all these things, and document it properly. And once the patient develops transfusion reaction, any of the transfusion reaction, whether it is TRALI, TACO, or fever, chills, rigors, whatever it is, we have to inform immediately, stop the transfusion immediately, inform the blood bank, because whenever there is a problem like this, we have to inform the blood bank so that they will take adequate steps to avoid this type of problems when we are transfusing next time. Now, graft versus host reaction is another important problem, but it is not very common in blood transfusion. We see rarely this type of problems in our patient. It is transfusion related graft versus host reaction is mediated by donor T lymphocytes that recognize host HLA antigens are foreign, and it can produce immune reaction, and patient develops fever, cutaneous eruptions, diarrhea, liver dysfunction, abnormalities. So all these things can occur in some patients, but these things are very, very rare. Another common thing is febrile non-hemolytic transfusion reaction. One we learned previously that hemolytic reaction with fever, febrile hemolytic reaction. This is febrile non-hemolytic transfusion reaction. Here patient will have fever but he will not have hemolysis. There will not be any jaundice but only patient will have fever, chills, rigors. Immediately stop the transfusion. You can give paracetamol. If required, injection chlorpheniramine malate and dexamethasone can be given. Then after sometimes if patient is stable, we can try to transfuse. Sometimes patient may not have fever afterwards. If it is an urgent transfusion, we can continue the transfusion or again inform blood bank and try to get a new pack of RBC or FFP or whatever it is. So immediately stopping the transfusion is very, very important. These reactions are characterized by chills and rigors, fever with chills and rigors and 1 degree Celsius rise in temperature. Now, allergic reactions, it may be immune mediated. Many patients can have generalized urticarial rashes after transfusion. For them also we have to give, if fever is there, paracetamol can be given. Otherwise, chlorpheniramine malate and dexamethasone or hydrocortisone injection will be more than enough in this type of reactions. Post transfusion purpura, it occurs due to platelet specific antibodies. This reaction presents as thrombocytopenia 7 to 10 days after platelet transfusion and occurs predominantly in female patients. So these things are very, very rare. We rarely see these things in clinical practice. So if you see the common complication after transfusion, it is febrile transfusion reaction without hemolysis and with hemolysis, that is hemolytic transfusion reaction, allergic reaction, TRALI, TACO. So these are the common reactions we come across in our clinical practice. In that we have discussed in depth about TRALI. TRALI is transfusion related acute lung injury. Here there will be antibodies formed against our system that produces it produces pulmonary vasculature's leak and it produces ARDS like clinical features. But normally it occurs less than 6 hours of the transfusion. Very rarely it occurs after 6 hours of transfusion. The close differential diagnosis for TRALI is TACO, that is transfusion associated circulatory overload. Here we have to give Lasix as a pre-treatment regime, and even if patient develops fluid overload, again treatment is Lasix and NIV. But TRALI should be treated as ARDS. That is very, very important. It is something related to ARDS, so the treatment option is also like ARDS. These patients will not respond to Lasix. That is very, very important. The patient who is having TRALI will not respond to Lasix, but the patient who is having TACO will respond to Lasix. So whatever occurs during, whatever may be the transfusion related injury or transfusion related reaction, we have to immediately stop the transfusion, and in febrile episodes give paracetamol IV, and if required, if the patient is not having diabetes or immunocompromised state, you can even give steroids which prevents further reactions. Chlorpheniramine malate will also may be helpful. Hemolytic transfusion, stop the transfusion, inform the blood bank, and next time when we are transfusing, we have to make sure that everything is proper and try to avoid transfusion reaction, because only if strong need of transfusion we have to transfuse, otherwise we have to try to avoid transfusions, because next time also same problem can occur. Allergic reactions are mostly due to the additives added to the transfusion pack. So most of the time this will respond to antihistamines and dexamethasone. TRALI and TACO we have discussed in detail. So we have discussed about one of the important problem during transfusion, that is TRALI. TRALI is very commonly seen in platelet transfusion and fresh frozen plasma transfusion. It is not at all common when we are transfusing RBCs or packed RBCs. Whole blood also it can occur. So that should be treated as ARDS in our ICUs. We need to give mechanical ventilation or NIV support, and we have to give conservative or restrictive fluid strategies, and so many other things we have to follow in ARDS patients that we'll see when we are discussing ARDS. Thank you.